Respiratory failure, by definition, requires arterial blood gas analysis. The patient can have low partial pressure of arterial oxygen below 60 millimeters of mercury, or can have an increased partial arterial pressure of carbon dioxide, generally above 50 millimeters mercury. If a patient is purely presenting with arterial oxygen partial pressure below 60, but a partial pressure of carbon dioxide within normal limits, this is called type 1 respiratory failure. If the patient presents with increased arterial partial pressure of carbon dioxide above 50 and a decreased partial pressure of oxygen below 60, then this is called type 2 respiratory failure. So note that both type 1 and type 2 have hypoxemia. The difference between the two is in terms of carbon dioxide or hypercapnia. In terms of practical aspects, you will be called to the ward or to the A&E for patients presenting with hypoxemia. So first, let's understand how hypoxemia occurs, because that is invariably present regardless of the type of respiratory failure. Let's have a look at general causes of hypoxemia: hypoventilation, ventilation perfusion mismatch, diffusion issues, right to left shunting, and altitude. On the left-hand side here, we have represented an alveoli, while on the right-hand side, we have a capillary. In between, we have a alveolar capillary membrane represented by this wall. Now, for us to better understand how oxygen gets transferred from the alveoli to the capillary, we need to look at Fick's law of diffusion, which states that diffusion or gas transfer is directly proportional to the surface area to the pressure gradient of a given gas and directly proportional to the gas's solubility, and it is inversely proportional to thickness. Let's have a look at a couple of values. So the alveolar partial pressure of oxygen is roughly 100 millimeters mercury, while in the capillary it ranges between 80 and 100, and we'll just take a mean of 90 millimeters mercury. On the other hand, in the capillaries or in the blood, we have a partial pressure of carbon dioxide of roughly 45 millimeters mercury, while in the alveoli we have roughly 40 millimeters mercury. Now here we're talking about partial pressures of gases. So in terms of where we measure it, we can measure it either in the alveoli or we can measure it in the artery if that is done by arterial blood analysis. So the same thing with carbon dioxide. It can be measured in the alveoli or it can be measured in the artery. Try get used to these terms of alveolar partial pressure or arterial partial pressure of oxygen and carbon dioxide. Now, in normal conditions, you have a given surface area, a given total surface area of your lung. The gas will transfer, more exactly, oxygen will go from the alveoli into the capillary based on its pressure gradient, while carbon dioxide will transfer from the capillary into the alveoli, again based on the pressure gradient. Now, if, let's say, the surface area or the alveolar capillary membrane was to be increased, then the surface area available for the gas transfer to take place would be increased, meaning that the transfer of any given gas, whether it's oxygen or carbon dioxide, will also increase. For example, when you do sports, when you exercise, the heavy breathing and the recruitment of alveoli during exercise, it will increase the area, the surface area of the alveolar capillary membrane, and more gas will be able to transfer in order to meet the oxygen requirements during the sports or during exercises. The opposite is also true. Let's say you have pneumonia in which the alveolar capillary membrane is reduced due to the illness, then the gas transfer of oxygen, for example, it will also decrease because there will be less alveolar capillary membrane available. Let's say that your patient for some reason stops breathing. For example, when you induce general anesthesia. What will happen? Eventually, the oxygen in the capillaries will be used up. As it gets used up, more oxygen from the alveoli will transfer in order to balance out the pressures between the alveoli and the capillaries. But because your patient is apneic, this oxygen supply in the alveoli is no longer renewed. Eventually, what will happen is that a gradient between the alveoli and the capillaries will no longer be present. What will happen to gas transfer? Well, anything multiplied by 0, it will give you 0, meaning that if there is no pressure gradient between the two sides, then the transfer will be 0. Let's have a look again at the alveolar capillary membrane. The transfer of any gas is inversely proportional to the thickness. If the alveolar capillary membrane was to become thicker, as it would in any inflammation, so the thickness increases, the transfer of gas will be reduced. Think of it like driving a car on a road with many traffic lights. It would take you longer to get to your final destination if you get stopped many times by the traffic lights compared to a road without any. Lastly, let's have a look at this coefficient. Is a given value for oxygen, and compared to the oxygen's K value, the carbon dioxide's K value is 20 times greater. What this indicates is that in a given scenario in which the surface area, the pressure gradient, and the thickness are all the same, the diffusion, the transfer of carbon dioxide will be 20 times greater compared to the oxygen transfer. Now let's take a frequently asked question. In hypoxemic respiratory insufficiency, why do we only have hypoxemia and we do not get hypercapnia? The answer lies in the coefficient. For example, in pneumonia, we have a reduced surface area. For oxygen, at its K value, the transfer will decrease. However, this transfer for carbon dioxide is not so drastic because it gets compensated by its greater solubility. So in essence, for a lobar pneumonia, for example, the oxygen will decrease, its diffusion will decrease. However, carbon dioxide's diffusion, it will be compensated by its solubility. Therefore, it will still be able to stay with the normal values. If this area was to increase, maybe affecting almost all the lung surface area, or maybe even all the entire surface area, you will get a point in which the balance will be tipped and carbon dioxide will start creeping up because the constant can no longer compensate. And yes, there is a certain point onwards, from a certain point onwards, in which carbon dioxide will no longer transfer.